Thanks, Tim. Thanks everyone for being here. Thanks for caring about this topic. These are research projects that have been really inspired by my work as a psychologist with the Complex Pain Service, and really trying to address some major gaps that we see between what is available in research and who we're actually supporting in clinic. And I was just saying like this, I was calling this like hot off the press data, but it's actually not even off the press yet because it hasn't even been published. And some of it was just being analyzed earlier this week. So I'll ask you to bear with me as I'm presenting some of this for the first time, but just really thrilled to be able to share some of our new and ongoing work. And I'll just start with an acknowledgement that we're joining here today on the unceded, ancestral, and stolen lands of the Musqueam, Squamish, and Tsleil-Waututh nations. You'll hear sort of themes of health equity throughout the work that I'm talking about, and a large part of doing work with this population has been trying to confront the reasons why our traditional ways of gathering knowledge have done a disservice to these populations. And I think there's a lot within the Indigenous ways of knowing and doing that is really informative of how we can be doing research better that will serve all of the young people that we come in contact with. So I'll start by briefly going over the overlap in pain and autism and sort of the clinical challenge that presents itself. And then I'm going to go through a series of projects. I mentioned these are, many of them are in progress. The first project is finished and has been published, where I'll review autistic representation in the chronic pain treatment literature. And then there's 2 qualitative studies looking at autistic youth and young adults and parents of autistic children, all of whom live with chronic pain. And then I'll finish up by talking about a quantitative study using micro-longitudinal data collection to look at everyday pain experiences in autistic young people and how that's leading into some of our upcoming work. If you've seen me present before, I love this picture, and I don't know if I'll ever retire it because I think it's just the perfect embodiment of what it's like to work in the pain field. So we know that pain is pretty much a universal human experience, but it's also highly individual, and no 2 people experience pain the same, and pain is highly variable even within an individual. And how pain is expressed and communicated really informs a lot of how we're able to understand and treat it. And this is where a large gap has existed in our knowledge about how to support autistic young people who live with pain. Has been a large reliance on that communication, either verbally, behaviorally, and trying to connect what we know about pain, which is always informed by our own experience, with another person's understanding of pain. And even if we're just looking at, anybody off the street and trying to understand their pain experience, it is highly complex. It's a biopsychosocial developmental phenomenon. And what I'm hoping to illustrate with this image here is that there's a variety of different factors that are exerting influences on how pain is expressed and experienced and understood by others. And those shift over the course of development in terms of what is exerting more of an influence and what those different influences look like. And so, if we're thinking about pain as being a phenomenon that's different between people, it's also highly dynamic in terms of from a day-to-day basis, a year-to-year basis. It's going to look different in terms of how it's experienced and expressed based on current and previous factors. So there really hasn't been much research at all looking at this overlap of autism and pain, but what we do know is that autistic individuals experience more pain than neurotypical individuals. And this is seen sort of across the lifespan. And that refers to both acute pains like illness and injury, as well as rates of chronic pains. There's patterns of hypo and hyper responsivity to pain that can make it more challenging to assess, more variability in the pain experience. And autistic young people experience more accidents and more co-occurring conditions that are associated with pain, particularly abdominal pain associated with different types of GI conditions. And we know that the pain disparity is more pronounced if there is a co-occurring developmental condition like cerebral palsy or intellectual disability. And there's some recent research suggesting that autistic individuals are overrepresented in pediatric chronic pain clinics. So if we think about the general prevalence of autism in population, what we're seeing in pediatric chronic pain clinics is rates of about 25%, either have a diagnosis or have clinically significant autistic traits. And one of the challenges with getting an accurate prevalence measure in pediatric chronic pain clinics is that many young people, because of diagnostic overshadowing, also because we tend to see more individuals assigned female at birth, maybe had not been picked up earlier for a diagnostic assessment. And so for quite a few young people, actually their journey to receiving an autism diagnosis begins in our pain clinic, making that referral. So it's likely that many of these prevalence estimates are actually an underestimate of the number of young people who have autistic traits or an autism diagnosis in our pain clinics. And the other factor that has kind of consistently shown up in the literature on autism and pain is that an individual's affective state, so experiencing things like pain-related anxiety, appears to be particularly important for this population. We know experiencing anxiety or any type of strong emotion is important for understanding pain in general, but this relationship appears to be particularly strong in the case of autism. And this is just to represent, some of the features that we would think about impacting an autistic young person and how that might then translate to our understanding of their experience of pain. So differences in social communication can lead to an under-recognition of pain, which can then lead to under-treatment of pain. Differences in developing and understanding relationships may mean that the therapeutic context in which we're trying to deliver different types of interventions may actually not be experienced as therapeutic, may be experienced as more stressful for these young people. A need for sameness or having difficulty with change or transition can be particularly stressful when you're living with complex pain, because pain is highly variable. It can be really hard to pinpoint exactly what is related to what, and it can create a lot of instability in what a young person's day-to-day life looks like. Hyperreactivity to sensory input may mean that sensory experiences that non-autistic folks would find to be kind of benign experiences can be described as painful. And many of the young people in our studies will talk about, the feeling of water against their skin, the feeling of certain types of clothing, loud noises being experienced as a physical pain over and above what they would describe as just an aversive sensory experience. But then at the same time, having a hyporeactivity to sensory input can often be understood as kind of pain-seeking behaviors, where young people will talk about using pain as a means of sort of modulating some of their other sensory experiences. And many young people in our studies have talked about, inducing a pain in one part of the body, which is not where their primary pain is located, is actually a way for them to modulate that primary pain experience. And I'll talk a little bit about some of our data around that shortly. But these are areas where there's really just a tremendous lack of research, and research that has largely relied on parent and caregiver report instead of engaging young people themselves, or has relied on tools and measurement systems that have been not developed or validated in autistic populations. So what is out there, we have to take with a pretty big grain of salt. So how does this impact our clinical practice? I was interested in looking at what the representation looks like of autistic young people in the chronic pain treatment literature. This is a literature that I reference quite frequently in my clinical practice and decision-making. And my sense was that there wasn't a great deal of attention to autistic young people, but it would be a pretty fair assumption that if a prevalence rate of about 25% is what we're seeing in our pain clinics, that should be reflected in part in the treatment literature. So this was a systematic review that was published earlier this year in the Journal of Pain, and there were sort of two primary aims for this systematic review. One was to review the existing gold standard treatment literature for pediatric chronic pain and to determine how often autistic individuals being represented in that literature. And by gold standard, we were referring to Cochrane reviews of interventions for chronic pain, and we were looking at all types of interventions, so physical, psychological, pharmacological. And then we also wanted to review the literature on the treatment of chronic pain, specifically in autistic children and young people, not putting the caveat of like, these need to be randomized control trials or that these need to be, Cochrane level types of studies. We really just wanted to see what is out there, including things like case reports. There was no representation of autistic participants across any of the studies that we looked at that had been included in Cochrane reviews. And I wasn't expecting a lot, but I was hoping for more than this. This actually, I think, is a pretty sad statistic and really reflects our prioritization of certain types of knowledge and research literature and certain designs and ways of conducting research, and that those are just not accessible and not reflective of our clinic populations. And my sense is that if you were to replicate this systematic review and swap out autism for a variety of other developmental conditions, identities and social positions, race, ethnicity, gender identity, that we would see similar gaps in representation, that really this research is being conducted on one particular type of patient, and those are not necessarily the patients that we see in clinic. When we dug a little deeper into why this representation was so poor, we found that that 17% of the randomized control trials included in Cochrane reviews explicitly excluded autistic children and young people. So one of the studies had said clearly in their exclusion criteria, we are not including autistic young people. The rest sort of mentioned more broadly that they were excluding any participant with a developmental delay or impairment. And interestingly, all of these were randomized control trials of psychotherapy that had an explicit exclusion related to autism or developmental conditions. And then we looked at sort of more implicit layers of exclusion. So we knew that there was about 1 in 5 of the studies were just not including autistic participants at all, but what were the rest of them actually doing, and why are we not seeing this representation? And what we found was that over half of the remaining randomized control trials had some layer of implicit exclusion for autistic children and young people. So these would be requirements like participants have to be generally healthy, English speaking, excluding cognitive impairments, requiring verbal communication. English speaking, that was a decision that we were sort of interpreting speaking to mean that there actually had to be some level of verbal engagement as well. And all of these factors were things that we thought, it may not be directly excluding autistic individuals specifically, but there may be sort of a bias towards this being a less friendly participation environment for these folks. And most of the studies that had some layer of implicit exclusion were studies of psychotherapy, but pharmacological and physical therapies were also represented. And then when we looked at whether there was any literature, aside from the randomized control trials, that could speak to the treatment of pediatric chronic pain in autistic populations, specifically children, youth, and young adults, what we found were mostly case studies. There was a range of interventions that were examined, but most of what we would consider to be our key established treatments for chronic pain, so things like cognitive behavioral therapy, physiotherapy, and intensive interdisciplinary pain treatment, were not examined. So often these were interventions that weren't necessarily framed as this is treating the chronic pain specifically. They would be things like, this is a surgical intervention to treat an underlying condition that's leading to chronic pain. There was a variety of outcomes reported, and in some ways, I think that was actually something that we thought was promising about that literature is that the outcomes weren't solely focused on pain intensity. We know that pain impacts young people in a variety of ways, and that's a big limitation of our existing treatment literature, is that often the focus is very much on pain intensity at the exclusion of things like functioning and mental health and sleep and other factors that might be important to consider. But generally, the quality of the evidence was extremely low and there was high heterogeneity. So it was really challenging to be able to draw any sort of overall conclusions based on the primary literature. So our takeaway from this study was that autistic youth are underrepresented and systematically excluded from clinical pain research, and the existing research is low quality. So this really motivated the following studies I'm going to talk about, because part of the issue is that I don't think we just need to continue doing randomized control trials of pain treatments and just start recruiting more autistic participants. I think we actually need to think a bit more critically about how might our interventions need to be adapted, or what do we need to understand about some of the specific mechanisms relevant for chronic pain in autistic young people to actually know that we're even offering an intervention that is going to be helpful for them. And as somebody who kind of spans both the clinical and research space, I know from our practice, just delivering off the shelf, like out of the box cognitive behavioral therapy for an autistic young person who's in chronic pain is generally going to feel like it's missing the mark. And so I don't think that kind of plowing forward with just doing things the way that we've always done them, but trying to be a little bit more intentional about recruiting autistic participants is necessarily the way to go. So a lot of our work has focused on trying to understand what are some of those experiences that are unique to autistic young people who live with chronic pain. What do we understand about the relationship between pain and other factors in autistic children and youth? And then how can we take that information and take what we've learned about how to do research thoughtfully with this population and then translate that into interventions? So I'm going to talk briefly about a qualitative study that we're in the process of wrapping up right now, where we're looking at the chronic pain experience of autistic youth and young adults. And this is the same methodology essentially that we're using for both this study and the next study I'll talk about around parents. So we've been doing both community and clinic-based recruitment. And for this study specifically, we're looking at a range of ages from 13 to 25, young people who do have an autism diagnosis without intellectual disability, who experience chronic pain and live in BC. And for chronic pain, we said any pain that has persisted or recurred for more than 3 months would be considered eligible. They didn't need a formal diagnosis of chronic pain because we know that's a huge barrier for a lot of young people. And young people provided informed consent or assent depending on age and capacity, and also were instructed about preferences for interview. And we gave lots of options with the interview. So could be camera on or off, a communication aid or tool could be used. They could have somebody with them if that felt more comfortable. We had some interviews that we broke up into different sessions, so we didn't have to do it all in one sitting. We had the option for young people to type responses into the chat if that felt more comfortable. And we ask a question at the end of the interviews about sort of feedback on the interview process and what we can continue to refine and iterate on. And a lot of young people referenced that even just having some of those options made them far more likely to participate in the research, sort of knowing up front that they're kind of, they had some autonomy in choosing how things would go. Then young people completed baseline questionnaires and then a semi-structured interview. And we've been using reflexive thematic analysis, which I know many of you in the audience are familiar with, as our primary method for qualitative analysis, which involves a process of sort of familiarization and initial coding of transcripts, and then development of themes that are sort of developed in conjunction with reflexive practice on the part of the person analyzing the data to really understand how your own perspectives, bias, and positionality might inform how you are reading and understanding and seeing the data. So for this qualitative study, we've had 20 youth participate so far. Actually, our original goal was 10, and the first 10 interviews were so rich and informative that we just kept going. And I probably should stop at some point, but as you'll see, there's maybe a couple of gaps that I'd like to try and address in who's represented in this sample before we close enrollment entirely. So we've had a range of young people in ages from 14 to 25. Nearly 90% were assigned female at birth, though if you look at the visual depiction of gender identity, you'll see that about 20% identified as having a diverse gender identity or questioning their gender identity, but then only 30% identified as being a girl or woman. So we had quite a few transmasculine young people participate in this study. That should say youth's self-reported racial background, not parent-reported, because we had youth and young adults report that for themselves. Their mean age of diagnosis for autism was 14 years, but there was a range from 2 to 23. So as you can see, these were young people who had a variety of experiences with accessing their autism diagnostic assessment. And that's something that we ask about in the interviews, sort of what was the process of receiving your autism diagnosis, and how might that have looked similar or different from your process of seeking a diagnosis for your chronic pain. And there's a huge amount of variability in our responses, and a lot of it sort of depended on the age at which the young person received their diagnosis. 60% reported their first personal financial situation as not comfortable. And we had 10% of the sample that reported their sexual orientation as straight or heterosexual. So there was quite a bit of diversity in sexual orientation and socioeconomic status. We also had really wide geographic representation from around the province. Very few had accessed any type of tertiary level services for pain. Some hadn't accessed services for pain at all. And there was a variety of types of pains reported, and many reported hypermobility syndromes, which is pretty consistent with what we see in our clinical setting. And I've got a nice picture of Michelle here, who's in the audience, who's the honors student, who's working with me on this project and who led the qualitative analysis. So thank you, Michelle, and feel free to interrupt me if I'm explaining your results wrong. But we identified 3 primary themes, and these are preliminary results, so might shift, but based on our understanding of the interviews so far, there was a theme around barriers to recognition and care in the healthcare setting. There was a load associated with navigating chronic pain. And then there's a particular importance to identifying and understanding intersecting identities in the pain experience beyond just this intersection of pain and autism. So I'll walk through a couple of these themes and sub-themes with some examples of quotes from the young people we spoke with. So in this kind of overarching theme of barriers to recognition and care in healthcare, there's a tremendous amount of diagnostic uncertainty that young people experience when they are seeking a diagnosis for their chronic pain. And often, even if they are provided a diagnosis, it may not feel fulsome or satisfying because the diagnosis is of a primary chronic pain condition. And that can be a really challenging one to understand and to feel confident in. And so this process of seeking a diagnosis for some young people would offer relief if they felt like they were being recognized and validated, but for many, it sort of enforced feelings of uncertainty and distrust. And in the process of seeking a diagnosis, participants described navigating medical bias, power dynamics, and gatekeeping. And this one young person from our study spoke about, feeling embarrassed about having to reach out to their provider and having to sort of remind them that they still hadn't gotten an answer yet, and feeling needy in the context of that interaction with their provider. There's also a lot of pressure for self-advocacy, and many of the young people in our study talked about the challenge of both advocating and trying to coordinate care within a fragmented and siloed system. And this shift in the responsibility from, a parent, caregiver, or healthcare provider and coordinating things to the young person having to navigate it themselves often led to these sort of aversions to healthcare settings, because the idea of even engaging in care coordination activities was so overwhelming and would kind of be seen as outweighing the potential benefits of seeking care. So this one young person from our study said, that was difficult with making phone calls here, making phone calls there. It's something that's hard for me to do, communicating in general. And another young person talked about this theme that was quite common amongst participants in our study, where they talk about sort of having to play a certain part of sort of like they knew how the healthcare interaction needed to go and what they would need to do, sort of like they were participating in a play. Like, this is what I have to say. It may not actually be what I feel or what I think or how I would communicate, but this is what I have to do to get the right care. And this one young person, I thought, said it really eloquently, saying, you say what you need to say to get what you need to get. There's also a loss of medical autonomy and agency, and keeping in mind that many of the young people we were speaking to were young adults who still talked about having to bring their parents with them to doctor's appointments, because they would say, as soon as that doctor knows that I'm autistic, they're not going to listen to me anymore, and I need somebody else to advocate on my behalf. And many young people said, it's something that I have decided not to disclose to my healthcare team because I know I'm going to be treated differently, or I'm worried I'm going to lose my ability to make decisions for my own care. And within that, there was also a number of young people who talked about like still having a lot of respect for their healthcare providers and feeling reluctant to sort of challenge somebody that they would see as being in like a medical authority position, and often saying things like, I understand why they have to do things the way that they do, but it still is really hard for me. And so I was just really struck by this sort of like very deep understanding of some of the social nuances of that healthcare interaction, and sort of understanding the role that they would have to play, even if it felt so alien to how they would want to communicate or be supported. And I think it's just a really relevant point to consider as a clinician who is the person in that position of power, who isn't in the midst of the suffering, and the fact that it may not be obvious always to us that the young person is feeling like they have to play this role. This idea of a load associated with chronic pain, or what many young people would describe as kind of a burnout associated with managing chronic pain, had kind of come up both in the context of balancing sensory experiences as well as balancing some of the tasks associated with navigating the medical system. So young people would talk about sort of this continuous self-surveillance and challenges in managing these sensory inputs. And this is both as I mentioned earlier, we would hear narratives around pain being overwhelming or pain being exacerbated by sensory experiences, but also pain as being a method of soothing, with young people saying, what is called self-injurious behavior is something that my doctors are always after me about, but actually that's how I regulate my nervous system, and I don't know any other way of managing the intensity of this other pain I'm experiencing than to inflict a pain on a different part of my body. Many young people talked about if there is any other sensory experience, pain being experienced as more intense, and then on the reverse, if they're experiencing more pain, other sensory experiences being more aversive. And many young people also talked about the challenge of interoception and not always being aware of what's going on in their body, or being extremely aware of what's going on in their body, but not being able to understand where it's coming from. Having difficulty distinguishing different cues and being able to tell what is a safe sensation and what is not a safe sensation. And this concept of medical burnout sort of alluded to in the earlier theme, but really a lot of young people would talk about the executive function associated with managing the healthcare system, and also that if they experienced any type of demand avoidance, that this made interactions with their healthcare team extremely challenging. And many young people would say, like, I have to mask if I'm going to go into a healthcare setting. This one young person said, it's like bridging a cultural gap to get my healthcare providers to understand what I'm experiencing, because they don't live in my body. And many referred to some of the kind of systemic issues. So this one participant said, having one good, hard to access doctor doesn't make a difference when the system gets in the way. So even if they had a couple of positive experiences, still the overwhelming experience within the healthcare system had been fairly negative. And a lot of young people talked about having to step back from appointments when they felt like there were too many expectations placed on them in terms of here's all the things that you need to do to get yourself better, and that pressure then led them to avoid the encounter entirely. And finally, we had asked some specific questions around like what else is relevant to know about your identity or your experience beyond pain and autism, to understand just generally what is your life like. And this came up in the context of those questions, but then also just throughout the interviews, there was a number of times where young people would reference things like gender bias, weight bias and stigma, cultural influences, social status and access to care, and even things like beauty standards that would influence how they perceived their body, how they understood and managed their pain. And the weight bias, beauty standards actually came up quite a bit for many of these young people, talking about how their pain would interrupt their ability to be physically active. And as a result, they would feel bad about how their body looked if they had some weight gain. And then that would make it more challenging for them to then seek care for their pain because they were expecting that I'm just going to be told I need to lose weight. We had these questions specifically about the autism diagnostic process, but then also asking, does an autistic identity feel like it fits for you? Is that an important part of how you understand yourself? And is that relevant for understanding your pain? And this was not a consistent experience across the young people that we spoke with. So some really saw autism as integrated with their identity and would say like, yes, there's nothing about my experiences that you can understand without understanding that I'm autistic, and that is sort of really a key part of understanding their pain, both experience but also expression. But many young people would also say, like, I do a lot of masking. I don't want anything to do with that. I don't want anyone to know. This is not an identity that feels like it resonates with me. I get that it's a diagnostic label that I have, but it's not who I am. And then finally, social support and belonging seemed to be really key sort of in both directions. So some young people were really well connected with other neurodiverse young people who also had chronic pain or illness and felt really supported by those social connections. Often those social connections were formed online, and this is something that I think is quite interesting and relevant, given that those are social relationships that often for many health professionals are sort of dismissed or not seen as being important. But for many of these young people, is that that's my only social connection, or because of where I live in this rural area, it's my only chance to meet other people like me. And then other young people would be navigating fairly significant isolation and may know one other neurodiverse young person, or they may know one other person who has chronic pain or illness, but didn't feel like they had anybody who really understood the intersection of those two identities and really spoke about the potential benefit of having some of that sense of social support. So I think the takeaways from the preliminary data that we have so far is that autistic young people do experience some similar stressors as non-autistic young people who have chronic pain. So things like diagnostic uncertainty is a fairly universal experience across chronic pain. But there are some additional challenges that are exacerbated by the healthcare system, and some additional considerations around things like sensory experiences that really we're doing a disservice to these young people if we're not considering how that might be relevant to their treatment plan and to our assessment of their pain. So we're conducting a similar study with parents of an autistic child with chronic pain, and part of this was sort of wanting to understand the experience of parenting as well, but also looking at the experience of some younger people where we wouldn't necessarily be bringing the child in for the interview, but to be able to hear from the parent's perspective. So these were all mothers, and the mean age of children, so it was a younger age range of children. We had more assigned male at birth, but still some kind of good spread in terms of gender identity. Mean age of diagnosis for autism was 8 years old, and around 60% reported their financial situation as average. So, still some diversity and representation, but maybe not quite as much as we were seeing in the adolescent and young adult study. I wanted to start off highlighting these findings with this quote from one of the parents that I just think like summarizes all of the experiences. Most people take their kids to activities after school. We take them to treatment. So many parents talked about how trying to navigate finding services that would be accessible and meet the needs of both autistic young people who also experience chronic pain and disability interfered with their ability to do anything else, to enjoy parenting, to take care of their own needs. So the first theme identified was around invisible suffering and parental exhaustion. Many parents felt completely isolated and would say things like, if I go to a support group for parents of autistic children, none of them understand the challenges of managing the chronic pain side of things, and then also just having no sense of whether there was anything available for supporting parents of young people with chronic pain. And for many of these parents, they would talk about how this is particularly challenging because of the parallels with their own experience. So many of these parents also had an autistic or neurodiverse identity, and many of them also had their own chronic pain. And so often that aspect of their experience was really interwoven with the story of seeking a diagnosis for their child. It's in some cases actually was considered to be helpful because parents would say, you know, I knew a bit more about what to ask for because I had already been through my own diagnostic journey. But then at the same time, sort of managing their own experiences of burnout and overwhelm and their own experiences of disability would make it really challenging to engage with all of the healthcare needs for their child. Parents talked about feeling dismissed from a variety of different angles and really just sort of bouncing from service to service and sitting on wait lists for years, and then just to be told either this is normal, you're overreacting, you're just an anxious parent, or being told you're too complex for our service, we can't see you, we only treat pain, or we only support autistic young people, we can't manage both. And parents talked about treatment inaccessibility from like systems level, sort of gatekeeping and siloing of services, and down to an individual level. So a lot of parents talked about demand avoidance in the context of their young person and sort of saying like, I don't offer all of the strategies that were told to them because I know if I present it as something that they have to do, that they're then not going to engage. And also managing their young person's sensory challenges, sometimes in the context of parenting other children or trying to meet their own needs, was described as really challenging. So overall, what we're hearing is that parents of autistic children with chronic pain are facing really invalidating and inaccessible systems, and that doing that in the context of managing their own needs, while that offers an extra layer of sort of insight and empathy, can also just kind of compound those challenges. So just to shift from the qualitative work, I'm going to spend the last couple of minutes talking about some quantitative work that we're doing, and this is part of our broader Living Lab at Home initiative, where we've been looking at ways to take research into the community in a more accessible way that's co-designed with folks with lived experience. And I'm not going to go into all of the background of how we developed and designed this study, but just to say that we did several rounds of different types of engagement, followed by some pilot testing before we implemented the protocol that we used here. And my plug for taking that approach is that we were able to increase our compliance with data collection massively by doing that. So when we did our initial pilot testing, when families were asked to fill out surveys 3 times a day on a smartphone for 2 weeks, we were getting around like 65 to 70% completion of data. And in terms of like the number of days where there was at least some data provided. And for this current study, our completion rate is closer to 95%, which I think is largely attributable to the fact that we did that pilot testing, we collected a lot of feedback from families, and then we were able to integrate that into our current protocol. So this is a study where we're not specifically looking at young people who have chronic pain. We're interested in sort of general prevalence of everyday pain experiences in young people who have an autism diagnosis and who live in BC. And we didn't exclude chronic pain. So there's kind of representation of folks who do and do not have chronic pain in this study. And what they were asked to do was these 3 times a day for 14-day short surveys administered to their smartphone, where we were asking about pain, masking, sensory experiences, mental health, school, social interactions, sleep, sort of a variety of factors that we know to be relevant for the chronic pain experience, both from the research literature and from our qualitative work. And I think importantly, there was also a lot of options provided to participants taking part in this study. So this data is a little bit old now because we are up into the 80s, I believe, for the number of participants that we have. But the last time that we looked at this data, when we had 61 young people who had participated, the majority had provided almost complete data collection. And we did give the option for them to opt out of any questions that they didn't want to see. And this was really a piece of feedback that was provided through our patient and family engagement, that they thought that would be a more trauma-informed approach. If there was something that was going to be really challenging or triggering for them, that we would remove that question for their data collection. And I think the sort of takeaway around the use of that is that I think we really benefited actually from doing that, that there's some folks who I think their participation was a lot better because they were able to have some choice in what they were seeing, and we didn't lose a lot of data as a result. And these may have been folks who maybe wouldn't have answered those questions anyway. So this is the distribution of pain experiences in terms of the number of participants who experienced a certain number of days of pain. And what you'll see is that many participants experienced pain at least half of the days, if not all the time. So pain is very frequent in this sample, and kind of looking more specifically at the different types of pains. So if you look at the top row, this is the max number of symptoms that could co-occur on the same day. We asked about a variety of different types of common pain experiences. And so you'll see that there's quite a few instances where participants were experiencing the maximum number of symptoms that they could in the course of the day. The bottom row shows the proportion of days with any symptom at all. So if they were kind of at that darkest shade of red, a 1, that would mean that on every day something was painful for them. And the rows in between show the proportion of days where they experienced any of these different types of specific pain experiences. So I think the takeaway from this is pain is quite present. It's also quite variable in terms of where in the body it's located. And it's not always located in one specific area for a particular participant. So every column here is one participant. And you'll see there's not many participants where they're only experiencing pain in one single location in their body. And we know from the general pain literature that multi-site pain is associated with worse outcomes. This is just a relationship between proportion of days of pain and age, coded by gender. And age was positively correlated with the proportion of days with pain. This is consistent with literature on the general population, that sort of through adolescence and into adulthood, the rates of pain increase. And this was mostly driven by girls, which again is consistent with what we would see in the general literature, that following puberty, we see a huge uptick in the rates of chronic pain in individuals assigned female at birth. And in our sample, it was driven both by girls and gender diverse participants. Many of our gender diverse participants were assigned female at birth, but identify as transmasc. And then the last bit of data I'll show from this, because we have a huge amount of data that's still coming in and that we are excited to dive into, but we were particularly interested in just looking at this relationship between pain and sensory experiences because it was coming up so often in our qualitative interviews in the context of chronic pain. And interestingly, this quantitative data is showing a similar pattern. So both sensory seeking and sensory sensitivity was higher on days with pain. So days where they were experiencing higher rates of pain, they felt more sensitive to other sensory experiences, but also there would be more sensation seeking, and some young people that would be talking about, seeking a sensation of pain somewhere else in their body. It may also be some young people interpreted the sensory seeking as being more stimming type behaviors. So I think the takeaway from what we've looked at so far is that pain is diverse and variable in autistic young people. Similar to non-autistic populations, we see associations with age and gender. And I think these findings on sensory experiences are really interesting, and I'm curious to dive into it a little bit more because we have this daily data that allows us to do kind of more temporal analysis than what we've done so far, but we can look at things like, does pain on one day predict sensory experiences the next day? There's a variety of different ways that we can kind of dive into that data, so quite excited to look at that. And I'll just wrap up by giving a brief preview to what's next in addition to finishing up these studies. So we're doing a variety of qualitative and quantitative projects to follow up on some of this. I'm working with my colleague in the pain service, Dr. Erin Moon, and a fantastic student, Victoria Belway, on doing a chart review of documentation practices within pain clinic around autistic identity and other identities and social positions to understand how often are clinicians actually asking about this in a chronic pain context and how is it being documented. And we're going to follow that up with focus groups with autistic young people who live with chronic pain who've accessed services in our clinic, as well as clinicians, to understand what might be some of the barriers to or considerations in asking about autistic identity and documenting this in the chart. We're working on adapting a data visualization platform that we've developed that's intended to support an individual's understanding of their own chronic pain and their self-management. We're adapting it for autistic youth right now, and interested in sort of testing out whether that might be a really low barrier, low cost intervention that may also support young people who are on our wait list. We have lots of plans for our ecological momentary assessment data, so the data I was just speaking about. And we have a lot of data related to pain, but we also have a lot of data related to other experiences that we're excited to dive into, particularly around some of our questions around masking and sensory experiences across different developmental stages. We're doing a scoping review of the literature on sensory sensitivity, autism, and pain to just see what else is out there, whether there is any other literature that is finding similar associations to what we found in our EMA study. We're quite keen to find a way to reliably detect the presence of chronic pain in autistic youth using large administrative data sets to be able to look at healthcare utilization and trends over time. And finally, a project that I'm super excited about, where we're looking at the experiences of parents and caregiver clinicians navigating communication with non-speaking medical inpatients, which isn't specific to autism, but I think has a lot of relevance in terms of our service delivery and how we can be making all of our medical services more accessible. And we know a lot of young people who have inpatient stays whose pain is not properly managed end up down the road in our complex pain clinic. So I would see improving communication options as actually being a really key intervention for preventing the development of chronic pain. And just a thank you to, there was more pictures of folks than I could possibly fit on this slide, many of whom are in the room, so I didn't intentionally forget you, but I just wanted to highlight a couple of the folks who contributed to the specific analyses that I described today. And happy to take any questions. Thanks so much.